So our purpose today really is to stimulate controversy. I'm hoping we can get a bit of discussion going. And so we're going to just, I think we'll just, if you don't mind, we'll just start on that end and move our way forward. And we're going to invite each of you to make a brief presentation.
Just the last 2 years I've been in administration, and I'm in the Office of the President at St. Anthony's and also the President of the Physician Organization. And they did ask me to speak a little bit about that arrangement because it's unique in St. Louis to have this Office of the President model. So we have many dyad structures within St. Anthony's, and in the Office of the President we have a CEO, Dave Sindelar, who's a career businessman and very good at finance and very important. We also have 3 clinicians, 2 doctors and a nurse, the CMO, the CNO, and then me in the role of the physician, leader of the physician organization. And we think this is very important because it brings the clinical expertise to the decision-making process. Everything's transparent. We publish all the meetings, publish all the financials, publish all of the quality rankings with people's names, put them from top to bottom. And if it bothers you that your name's on the bottom, you've got to do something about it. So the transparency is really helpful in just listening to the people's voices. So we do think that that's the model to be physician-led, will allow us to provide the best quality and the best care.
You know, the governor before showed a picture of that car that was disassembled. The healthcare in that car is actually more than the steel in that car, okay? That's very real. If we think about healthcare cost inflation, if we went back to 1930 to now, a pound of coffee right now would cost $68, okay? So imagine that, your $5 latte just went to $50, okay? So that's what we're talking about, and that's why it's important for us as employers. Now today, I will tell you this, I am here representing the Midwest Health Initiative. So I'm on the board of the Midwest Health Initiative. What we do is we gather data and to drive better health decisions. This is the St. Louis metropolitan area, broken up by zip code. These are just adults, avoidable hospital visits. Green is better, meaning green is under 11% avoidable emergency room visits. Red is over 17%, and the yellow and pinks are kind of in the middle. Okay, so just look at that just very briefly. The average is 15% avoidable. Okay, that's interesting. Now, we know in Oregon, they actually have a statewide avoidable rate of 10%. So let's see how we stack up against that Oregon criteria. And you can see there's only several zip codes that even come close to meeting that, right? And they're right on the verge. They're like at 9.8 or something like that if you were to dig into the data. Now, the reason that this is interesting is you might be hypothesizing, saying, well, that's because people don't have primary care physicians. How many have heard that hypothesis? So let's actually look at that, and let's look at by health group here, different medical groups in St. Louis, and let's look at what they're avoidable, that same data, and look at avoidable visits to the emergency room. Okay, goes from 12% up to 17%. 12%, 17, so they're all over the Oregon average. And there's a definite statistical significant difference here between 12% and 17%, meaning these medical groups are doing different things. Right? Okay, what does that mean bottom line? $50 million of opportunity sitting there. $54 million. Wow, that's pretty interesting. So what does that mean from an employer standpoint? So first of all, let's unmask and make transparent the cost of care. That's like going to the grocery store, and one store has a $4 gallon of milk, and you go to another grocery store, and it's a $20 gallon of milk. Right? Which one are you going to choose, right? Now, I can maybe get my employees to choose that $4 gallon of milk, but will they choose that $600 MRI?
Pharmacists are truly very well equipped with that clinical knowledge that they can step up and be those drug experts. So as I take a look and kind of guide you through my practice is located in a small rural community about 2 hours south of St. Louis. It's called Health Priorities. It is a consulting pharmacy that does not dispense medications. So it is licensed and recognized as an accredited diabetes education center. What I do is I collaborate with physicians to help them manage their most difficult to control patients. And I empower patients to help them manage and/or prevent complications of most chronic conditions. My responsibilities include performing comprehensive medication reviews. I'm involved in transitions of care and chronic care management. What I do and what other clinical pharmacists do does not replace the services that physicians provide, but rather complements what they do.
As Governor Leavitt mentioned, we applied for and received the, we were recognized as an awardee convener from the Centers of Innovation for the Bundle Payment Program, for the BPCI program. We have convened now for 60 other orthopedic groups and become clinically integrated with those groups in 26 states and 60 cities. So we are now managing about 4,000 total joints a month and are at risk for the cost of those total joints as with the groups that we're working with. And we are managing over $1 billion of post-acute care spend. We received the Strong Start grant, and we have a tremendous, we have I think, a team of 8 or 9 nurses and social workers who are really the heroes of that program, who go into the community and have developed community partnerships with over 140 organizations across the state, both in St. Louis and Kansas City, to help reduce that preterm delivery rate.
I'd like to know a bit about what you are doing in partnership with others and what makes a good partner in the context of value. Dr. Bowe, would you mind if we started with you?
No, I'll be happy to. I think we're doing a lot, and I mentioned last night, we've been in risk for over 20 years, and so I think nobody ever gets it perfect, but I think we're doing a good job, and I think it really positions us well for the future because population health is so important. And
so describe what you mean by risk, because I think that's a very interesting point that not a lot of people may know about your hospital.
Rules have changed to really make it more fair, especially from the standpoint of having the risk stratification, so that now the patients you take care of are all risk stratified according to their diagnoses, so that there's a fair amount of money that goes into the pool for you to take care of them. And to adequately take care of them, it takes many people. So it's not just the physician and the patient. And what we found out is that we have a whole team of people that work with the physicians to understand how the program works. We have care managers in the hospitals. We have transition of care people. We have now people that go out to the nursing homes, not just once a week, but on a daily basis to make sure people are getting the care that's needed. And as I said, success in this is no accident. Success is only achieved through hard work and smart work. And yet, I think it's a model for the future that if you get everybody on the same page, and what I love to tell the patients is we're investing in your health.
One thing that our medical group thinks about, and when they take the Hippocratic Oath about first do no harm, that also includes the financial harm to the family that's receiving care. According to the Federal Reserve, the Federal Reserve Bank, 47% of all families in America would have trouble paying a $400 unexpected bill. And so from our standpoint, I think that, and this is for the state legislators in the room, the idea that a health system can have a gag clause and prevent knowledge of a price is morally reprehensible. The idea that a health system can have a covenant not to compete against a physician who has a disagreement over medical care, to me, it's un-American.
I guess all I might add to that is, I don't know if anyone should be forced to release their pricing, but it's kind of like, again, if I'm going to one car dealer and they'll tell me what price they'll give me, and another car dealer is saying, I won't tell you what that price is. I'm guessing I'm probably going to favor the one who's going to at least, talk to me, on the phone and say, hey, here's roughly what the price is. And I think over time, you're going to have the same thing in medicine. Now, what has to happen for that? Well, a couple things. So first of all, plan design is part of it, working with the insurance companies, because right now there's really no incentive for, in most medical plans, there's no incentive for the patient to do that, right? Because why? It's going to be paid, and all they have to worry about is their out-of-pocket. Guess what? Their out-of-pocket's the same regardless of where they go to. So until you start hitting that out-of-pocket, and all of a sudden they feel that, hey, if I go over here, it's this, but if I go over here, it's this, same thing, why wouldn't I go over here? It's back to the $4 gallon of milk or the $20 gallon of milk. They have to understand what that gallon of milk's costing them. And that's, I think actually employers have a lot of responsibility there, first in plan design, but secondly in education and helping people understand that. But it also gets back to it has to be the patient ultimately, right? I have to be able to ask that question, hey, why am I paying more over here?
Well, thank you to the panelists and to all of you for your good questions, and to Signature for sponsoring the event.